I will be talking about collaborative therapy, and one of the important aspects which I'll be discussing is the philosophical stance by Harleen Anderson. And so to introduce the philosophical stance, it is a way of positioning ourselves through our thinking, talking, acting, connecting, responding with the other person. So collaborative therapy was developed by Harleen Anderson and Tom Anderson. It is influenced by other theories such as most modern, social construction, dialogical, narrative theories, and client-centered approach. It can be used in numerous settings such as family, individual, or group. One point which Harley emphasizes in her talk is the interest in learning the client's language, which can be created through social context. Our thoughts, meanings, experiences can be shaped through our interactions with others. Language is a powerful way of expressing ourselves and influences our lives as well as the world we live in. Through interactions, experiences, and language, we can also attain knowledge of understanding others and ourselves. So Harleen believed there are two ingredients to collaborative practice, which she also sees it as the heart and spirit of her research. So the first is collaborative relationships, which orient ourselves to be, to act, and respond with another person, so the other joins a therapeutic shared engagement and joint action. So that we live in a joint action and the meeting, interacting with one another is mutually responsive. The second is dialogical conversation, so which involves mutual inquiry, an engaged connection of sharing, exploring, crisscrossing, and weaving of ideas through thoughts, opinions, and feelings, through which newness and possibility emerge. So it's an interactive two-way process. She also mentioned that dialogue involves a process of trying to understand the other person from their perspective, not ours, and that relationships and conversations are influenced with each other. The manner of engagement, the way we develop a relationship with the other person, influences the quality and the kind of conversation that we have with each other, as well as the conversations we begin to have with each other will influence the kind and quality of our relationship. So from the video, Harleen emphasizes on 7 characteristics of the philosophical stance to enhance the relationship between the therapist and client. So number 1 is conversational partners, which is the mutual explorations and shared information in what the client needs. The therapist is seen as a host and at the same time as a guest in the client's life. Number 2 is relational expertise, which is shared knowledge, beliefs, and resources. So the expert is an expert on themselves, such as their life, their problems, and its solution, while the therapist is an expert on the process and space for the collaborative relationships and dialogical conversation. Number 3 is not knowing. The therapist is the teacher and client is expert on their life. A therapist maintains a not knowing, curious, respectful, and humble attitude by inviting the client to find the resources within themselves to change. Number 4 is being public. The therapist being open with their inner thoughts so the client does not feel that there is a private conversation about them that they're not part of. The therapist contributes to the conversation by putting forward possibilities of things to talk about or ways to talk about them. Number 5 is mutually transforming, client and therapist in a continuous and mutual process, both each continuously influenced by the other and an active process for both the client and the therapist. Number 6 is uncertainty, where the client and therapist are on a journey together into the unknown. So together the client and therapist create the paths and determine the destination. And lastly, number 7 is everyday ordinary life, ordinary type of relationship. As Harleen states, they are the belief that humans are naturally resilient and they have the desire for a healthy relationship and quality of life. We should not only see the person through the diagnosis, but view the client as a unique individual.
The following is an overview of narrative therapy. Narrative therapy was created by Aussie social worker Michael White and New Zealand social worker David Epstein in the 1970s and 1980s. Narrative therapy follows a postmodern view and a social constructionist view. Narrative therapists want to examine how the power structures in society that influence our knowledge and our truth. Therefore, they want to examine how the dominant culture creates messages that impact us in our day-to-day lives. Narrative therapists believe the meaning of life can be discovered in the stories which we receive from the dominant culture and the dominant discourses and our local discourses. Well, dominant culture, you may or may not know, is basically what's dominant in today's society. What has the most power? What has the most privilege? Privilege is given not so often because of entitlement. It's often given because you come from a place of privilege, which is not always right. So the dominant culture creates these messages when somebody has power. If you have money, if you have power, white male tends to have more stability, less racism against it because of its dominance in society in the past. Other cultures or other places in the planet, it might be a particular class or hierarchy, such as in India, certain cultures have, certain tribes have higher levels of hierarchy than the other. In Kenya, I know when I traveled there, it was similar. Therefore, these messages are passed on to other people that either I'm entitled to it, or they create a sense of privilege, or they create a sense of hopelessness, or they might create both. Therefore, the narrative therapist wants to discover how these forces in society of dominant culture and dominant discourses have impacted the person's life and created their own story. Local discourses are other messages that might be not so much on a societal level, but say your own personal unique story of your family or your context of your workplace that might be unique to yourself. The internalization of these messages creates a person's story. The messages that we receive from the dominant culture, we wind up internalizing. For example, the media may portray women a certain way, need to look a certain way, therefore they internalize that they have to look that way, as well as men. A man has to look buff, therefore he's a man if he's buff. And then that internalization process impacts how we see ourselves. I'm not so buff, therefore I might not feel like a man, or might not think that I measure up to what a man is, or I might be saying to myself, I don't feel so strong or manly today, so to speak. Our narratives create our identity and our sense of meaning. So as we believe these stories about ourselves, they create our identity, and they create a sense of what brings meaning to us and what doesn't bring meaning to us. One key value or belief in narrative therapy was discussed by Diane Gayhart, is that the problem is the problem, not that the person is the problem. Rather, they are a person with a problem. We as therapists want to help them externalize this problem and bring that out as we're meeting with them. So it's in this process of the person telling the story, they're externalizing it by bringing it out and telling somebody else, and they're starting to separate themselves from the problem and realize that they are not the problem, that the problem is the problem. In therapy, language is looked at, and we pay particular attention to how the client constructs their world, the good and the bad. And then through paying attention to that, the therapist can become aware about the different layers of the person's narrative, and starts to encourage the client to avoid using totalizing language such as I'm always, or I should have, or I must have. Trying to not tell them how to do it, but just kind of gently encouraging them and suggesting a different way of writing their story. Questions are a very powerful tool for narrative therapists. They help us to get curious with the client. They help us with what Geehart describes as the thickening of descriptions. So pulling apart and expanding on the story, it helps us understand the client more, and it helps the client begin to process and deconstruct the messages from the dominant culture. Ultimately, our goal, and we realize that we can't change it for them, but we're helping them to basically tear apart these messages so they can reconstruct and reframe and start to create a new story for themselves where they're not so controlled by the dominant forces and the local forces inside of their head that tell them that they're no good and not worth anything. We start to help them to have more optimism in their life and a bit more hope in their life. We realize that not all their problems will go away, and that to think that they're going to be totally hopeful all the time is unrealistic and not real. Therefore, we help them to come to a little more of an understanding of their true worth and value. As I mentioned earlier, the client begins to rewrite their narrative, which is a fluid process, and it's not an arrival point per se. As they go through the process of externalizing their problem, and as they go through this process, they're rewriting the story. And we are a part of their journey by asking them questions and getting a little deeper descriptions of that story. The person will move back and forth through hope or no hope, or sadness and happiness, the like.
So, we are going to continue now talking about the actual techniques of narrative therapy and how they are applied in clinical situations. I'm just going to dive back on Greg just a little bit so I can tie in some of the sort of case assessment moments with the actual techniques of the clinical practice. So just go back a couple of moments into Gayhart's lecture, and then we'll move forward. Okay, so in an early assessment phase, like I said, I just want to mention this very, very briefly because it's important when talking about into specific treatment methodologies. So when a client heads into the office of a narrative therapist, they are weighed down by problem-saturated stories. And what that means is that their life is weighted with like crappy feeling all the time, that when they look at their worldview is dominated by problems, and they have a really hard time seeing anything positive. And what is really required of the therapist when hearing these stories is to listen for unexpected outcomes. And these are sort of sparkly gems in the darkness, and they indicate that a person was surprised by something really good that happened. Like, things have been really terrible, I feel really awful all the time, but I had success at work. Small things that can really be used as touchstones as therapy is moved through. The therapist also really begins with the client to talk about the dominant discourse around culture, around gender, around sexual identity, around class, around ability, all of those things, versus their sort of local and alternative discourses. So if they don't fit into one of those very hegemonic categories, that people have an opportunity to pursue identities that feel a better fit, and are in perhaps opposition to that dominant discourse, and perhaps it is that dominant discourse that is causing a dearth of problem-saturated stories. During assessment, the therapist will then seek to set some goals. The overarching goal, of course, is to allow the client to enact their preferred identity, and being able to externalize their problems. Early phase goals are when we start externalizing. So a depressed person becomes a person with depression. So instead of a person simply walking around going like, I'm depressed, where that is an adjective that describes them and becomes a sort of dominant voice in their identity, that adjective is turned into a noun, and that I'm a person with depression, and that is a relationship that can be altered. Middle phase goals target symptoms of the relationship with the problem. So if that problem is anxiety, the middle goals target your relationship with your anxiety and what ways you can alter that relationship. And late phase goals are really about finding bigger context into your personal and relational identity within your community. And a really good example of that actually was in our unit on multiculturalism, where the woman, Anna, who's Cuban, sought counseling because she was feeling depressed in her new life in Hawaii. And she was encouraged by the therapist to seek out Spanish-speaking communities, maybe not necessarily Cuban, but she was able to reconnect with some Spanish language speakers through her church, and also to reconnect to her spiritual life, which helped to allow her to enact the identity that was so close to her of being a Cuban woman, even though it was difficult in Hawaii. Narrative therapists use a number of techniques in order to help facilitate change within their client and allow their client to enact their preferred identity. The biggest technique, like the biggest thing that they're looking for, is externalization, and the goal being there to separate the person from the problem, and to help the client understand that they're not their problem, that their identity is not based solely on this problem that they have, and that they are in a relationship with their problem, and they can better that relationship with their problem and relieve their symptoms. Below is a list of all of the different techniques, which we're going to talk about separately, so I'm not going to read the list to you. The first technique that narrative therapists undertake is called mapping influences of problem and persons. And that sounds really much more complicated than it is. Basically what this is that it is a two-part technique designed, again, to take that problem from being the arbiter of someone's identity to being an external relationship that they have in their world. So the part one is mapping influence of the problem. And what this means is that the therapist will talk to the client about their significant others and about the ways in which the problem that they're facing impacts their significant others. As Gayhart points out, at the end of this, the client can feel pretty terrible, because what it does is it opens up the problem in a way bigger scope, because suddenly the people in your life that are significant are not just necessarily your significant other, but people you work with, your children, your friends, potentially if you're a child, your teacher, all of those relationships in your life that have an impact. And so at the end of this, you can feel overwhelmed by the scope of the problem because it has bled into so many areas of your life. So it's really important at this phase that the therapist doesn't abandon the client, because then the problem can feel even bigger and can become more internalized, which is the opposite of effect. So then what we want to do in part 2, mapping influence of persons, is to begin to use externalizing language. So then we start talking about a client's relationship with their symptoms. So we'll stick with the example of depression. So if the person is struggling in their relationship with depression, it's not about them being a depressed person. And we want to really take away that language of saying you're a depressed person and saying like you are a person with depression, a noun, like you are a person with coffee. And really understanding that you have a relationship with that depression, and it's a two-way relationship. And the way that depression can enact on you, you can enact on your depression. And through treatment, you can find ways to relieve the symptoms of that relationship. So that's really what the goal of part 2, mapping the influence of persons, is about. One of the things that Diane Gayhart really makes mention of is sort of the history of narrative therapy and White's contributions as the sort of like godfather of narrative therapy. And she also really mentions the sort of like more obvious treatment things like mapping influence of persons, and then also the more subtle elements of finding ways to externalize problems. So one of the things that she adapts from White is this thing called externalizing conversations, which is a lot subtler. And so it's there's 4 different categories. So category 1 is really about using client's language. So we don't want, in this case, we don't want to make the client feel like the therapist is above them with their language. We want to use the client's language, talk about their feelings in their same language. We don't want to make them feel in any way like shamed or that the problem is so much bigger than them. In category 2, really similar, to mapping the influence of a problem, where we map the effects of the problem. So we talk about its effect on your schoolwork, on your significant others, on your family, on your friends, on your life. And then category 3 is evaluation of effect. And basically, as Gayhart points out, and I think she really sums it up really nicely, like, how are you feeling about this? Like, are you all good with your situation? And with its effect on your relationship with the symptoms. So it's really about saying, like, are you cool with this? And if you're not cool with this, we move into category 4, and it's like, why are you cool with it? What do you want to do? Do you want to change? Do you want to change your relationship with your problems? And if that's the case, and the client expresses that desire to change, the process of externalization of the problem has begun. So 2 more of the techniques. We have externalizing questions and problem deconstruction. So externalizing questions are specific questions that allow the person to begin to understand that the problem is not an adjective. Example, I'm a depressed person, but to a noun, I'm a person with depression. In the same way that you would say, I'm a person with coffee. And obviously, coffee and depression, you have a different relationship in your life with those 2 things. But regardless, whether you're talking about coffee or depression, what we're really trying to do here is to allow the client to understand that they have a relationship with their problem. And that all things in life are a relationship. In the same way you have a relationship with your pets or your coffee or your parents or your depression. So what this assumes is that a person is in fact separate from their problems. From the beginning, whether they feel they're separate from it or not, they are in fact separate from it. It also assumes a 2-way relationship with the problem. So while people feel incredibly impacted by their problems, of course, depression can does weigh heavily on the spirit, what this attempts to do is allow people to recognize that they can also enact agency over their problem, that the relationship is a two-way relationship. Problem deconstruction is about understanding the way we construct meaning through dominant discourse, that like sometimes our problem is a result of our tension between what we believe, our values, and the values of the dominant social discourse. And it allows us to be conscious. What problem deconstruction does, it allows us to be conscious of our choices of how the dominant discourse affects us. So what this does is allow us to say, like, no, I will not allow myself to be negatively impacted by homophobia. I will not allow myself to be negatively impacted by racism to the point of feeling depressed about it. Of course, racism has a negative impact. And then it targets problematic cognitions, feelings, and attitudes. And those are, of course, those problematic cognitions, feelings, and attitudes are impacted by history, conflict, context, effect, and interrelational strategies. So in the ways we relate to our fellow human beings on the planet, and recognizing that those relationships are in fact also two-way. So up next, we have mapping the landscape of action or and identity or consciousness. So what this basically is sort of like the movie version of a really great outcome. So a unique outcome happens and everyone is really thrilled. You're really thrilled. This feels like it's a piece of the identity that you would like to express moving forward. So what you will do with your therapist is that you will map the landscape of that action. And Gayhart calls this the video camera version. It's like watching the movie of what happened. So you talk about like where you were, who was there, specifically what happened, like the plot lines. Like I woke up that day, I had a good breakfast, I went to school, etc., etc. And then you interpret the event. So you map the landscape of identity or consciousness. And that sounds really, really complicated, but basically it would be like the internal movie, the movie inside of your spirit when that was happening and what you were feeling, why it was so great, why that outcome was unique, and how and what it was about you, about your identity, about your consciousness that brought it on, and where that fits in your identity, and how it can be perpetuated and how it can be extrapolated to other situations, so you can continue to have these really positive outcomes, and they can be brought into an enactment of your true identity, and allows you to have some agency over your experiences rather than feeling overwhelmed by your problems. So narrative therapy, while not super old in the grand scheme of things, is still developing. Like many postmodern theories, it continues to develop. And there are some newer and newer ideas coming out all the time. So we're going to get into some of those now. Developmental psychologists and theorists talk about scaffolding behavior, where we show children, older people, younger people, where we sort of demonstrate a behavior for them and sort of allow them to see the steps that they can take. But in terms of a psychological approach, for me, this is more a very subtle technique that's closely related to Miller's notion of the zone of proximal development. Both of scaffolding and ZPD come from Vygotsky, but these are slow things to happen. And what we're trying to do in these cases with our clients is move them from the familiar to the novel. So from things that they understand and are tied deeply to their identity to new perspectives and new ways of enacting their preferred identity. So the very first step in this is called low-level distancing tasks, which basically just highlight things that the client already knows about themselves. And then we move into medium-level distancing tasks, which is more newness and more comparison to unique outcomes. So we talk about one unique outcome as a sort of low level. And then in the medium level, we use other unique outcomes and compare them with unique outcomes that we already know. So maybe something happens that you don't see as being a unique outcome, when suddenly these medium level distancing tasks allow you to go like, oh, that is kind of like that other thing that happened that was really good. Right. And then we move into medium high level distancing tasks. So we're kind of smack dab in the middle right now where we're able to begin to reflect on a chain of unique events. So we're able to understand why more than one continue to happen. What is happening within our identities to allow this chain of unique events to continue? When we get to the high level distancing tasks, it's a much more abstract sort of reflection and ability to focus on like the moral of the story. So what is this chain of unique events and unique outcomes telling us? What should we take from all of this? And then when we get to the high level distancing tasks, we are then able to create action plans to continue to allow these unique outcomes to occur in sequence, to be able to continue to reflect upon them and to incorporate them into our identities while continuing to externalize our problems. If you are a person who has worked in consent education or a person who really values consent as a human being, as I hope we all do, this is something that we can really get behind. This is something I really get behind. Permission questions. So permission questions are basically asking permission to ask a question. I think a lot of people really believe that therapists have a sort of like carte blanche to like dive into the deepest, darkest parts of ourselves. And like sometimes we don't feel comfortable allowing someone into that. And it is the responsibility of a narrative therapist to ask permission. So Gayhart's example, I think, is a really good one, is to say like, would it be all right if I asked you about that sexual abuse that you've endured? And if you're not ready to talk about it, in that moment, you get to say no. Not yet, not today, no thank you. And what this does is that it emphasizes that there is, in fact, actually a democratic relationship between client and therapist. And what this democracy does, it allows the client to continue to develop a strong sense of agency. If a client is allowed in a therapeutic relationship to say, no, I don't want to talk about that, they're able to continue to say, like, outside in other areas of their lives, like, no, I don't want to talk about that. No, I don't want to do that. No, I'm not ready to do that. No, this relationship is not working for me. And the more you can practice these sort of like different elements of consent, the more likely you are to be able to develop a strong sense of agency. And this ability to say no also maintains and increases a working alliance. The more you know that your therapist is not going to invade your privacy without your consent, the more you can trust them and the stronger that alliance, can be. The other thing that really helps to maintain a democratic working alliance is situating comments. And basically, what situating comments are is that, like, the therapist, instead of positioning themselves as an authority, they say, like, hey, so I read this article that sort of outlines what you're talking about, or one of my colleagues says, and just really making reference to your source, where you got this information that you're sharing with your client, so that it isn't just like, hey, I'm the boss and I know everything, but that like, when I was in school, I learned, or my training says, or in other experiences with this situation that you're dealing with, these are some things that might be effective. And what it does is remind the client that the perspective of their therapist is only one person's perspective, that the therapist is in fact an individual with their own perspective, and you don't have to agree with it. And so it really, again, these two things really, really allow for the building of agency and for a really strong democratic working alliance. Narrative reflecting teams, leagues, and memberships. So these are sort of like more collective sort of models of treatment. So the first one, narrative reflecting teams, these are for the therapist, and they're often done in postmodern therapeutic methodologies. And basically, as a therapist, I would have colleagues look in on my sessions with a client, and they look for things like instances of unique outcomes that I might have missed, ways in which we can further critique the dominant discourse, and look for ways to support problem-saturated descriptions. So maybe I've been in deep with a client, and it becomes difficult for me to see the forest for the trees, and so they're there to just provide some additional perspective, which allows for the client to have increased agency. which is ultimately one of the goals of externalizing problems, is to allow the client to have agency over their relationship with their problems. Leagues are associations of clients struggling with the same issue. For example, online support groups for people with eating disorders. I know at the end of her lecture, Diane Gayhart has a list. There's an online bulimia association, and sometimes these groups are conceptual, and sometimes they're geographical. There is also they appear to work really, really well for children, particularly children with behavioral problems, and can be really, really beneficial in like rewarding positive behavior. Membership is another one of these things, and membership solidifies preferred identity. So like you get to join an organization that represents your preferred identity. So like young queer folks, people of color can join community groups that reflect their preferred identity. And you cannot join those groups until you reflect that identity. So it represents an accomplishment and a success in the therapeutic relationship. This to me is like amazing. And a thing that I know would be really effective for me as a client. And I think it's something I would really incorporate into my own practice. So definitional ceremonies. You hear in Shelley Turcotte talks a lot about ceremony in Indigenous counseling, and I think like we think of the word ceremony as non-Indigenous folks, we think of the word ceremony to be like religious or societal, like a wedding ceremony or a graduation, something that's like really codified. But ceremony can mean kind of anything that is reverential and celebratory, and this definitional ceremony is something really, really celebratory. So it occurs in a later phase of therapy. It doesn't have to be just one time. It can represent like a lot of sort of separate success points, and it really is super powerful. I sort of got teared up listening to Gayhart talk about it, and it allows clients to reinforce and reclaim their preferred identity. One of the examples that Gayhart uses is that like for a woman who's been sexually assaulted to reclaim her identity for her family, for her current partner, for herself in one of these ceremonial ways. So basically, what happens is that significant people are invited to bear witness to the emerging preferred identity. So first, the client shares their new or emerging identity story. So they share how they got there, what that identity looks like and means for them. Then the witnesses retell the story that they just heard, but they also include things that they've noticed in their relationship with the client and the formation of their new identity. So they can talk about things like, I really noticed like how strong so and so seems now that they've begun to explore this new identity, or we've been spending so much time together and we really stopped fighting, things like that. And then the client retells the retelling. So they then incorporate aspects of the witness's retelling into their new identity formation. So then they say like, oh, and haven't been fighting with my mom as much, and it's really meaningful to me when she says blah, blah, blah. So it becomes this very relational, very like shared and very powerful moving experience for the client and for their client's significant folks. The other thing the therapist can do is letters and certifications. So in a letter, the therapist, it's pretty well as it sounds, the therapist writes a letter to the client and includes some reflections and questions regarding their progress toward their preferred identity, and can really like cement change for the client, and it can also really reinforce the change that they've made and the success that they've had, and like allow for ongoing development. And this happens like later in therapy or toward the end, but it can be a powerful tool throughout as well. And or certificates. This works really, really well with children, but it signifies achievement. And ultimately, at the end of the day, if you're seeking out therapy, this kind of therapy, you're looking to achieve the ability to enact the identity that you want, to be the person that you know is inside of you, regardless of the conflicts that you've had or the problems that you've had, and that to take those problems outside of yourself. And sometimes like having that written down on a piece of paper can be really, really, really moving and really reinforcing in a positive way of that new identity. Okay, so tapestry weaving is a way that a narrative therapist can work with diverse client groups. And basically, narrative therapy is because it exists to challenge dominant cultural discourses. It's a really, really effective way to deal with a diverse clientele. And we heard examples of like varieties of the ways that multicultural and feminist and indigenous counseling can be woven in with narrative therapy. Turcotte's example of ceremony, as I mentioned before, is a really great example, and this all exists again because cultural issues are at the heart of narrative therapy. It's about figuring out your identity in relation to the identity that is expected of you, or you are in conflict with, or that you are in disagreement with, or that you align with. And those are alternative identities, or ones that, if you're a straight white guy, in line with, but also like what that looks like for you. But if you are a racialized person, existing with the dominant cultural discourse can be really, really conflicting and can cause a lot of trauma and impact. And so narrative therapy can really highlight the impact of marginalization, similar to sexual identity diversity, and not mentioned by Gayhart, but also gender identity diversity. There's a lot of conflation of sex and gender, and there's not a lot of mention of gender here, but for trans folks, for non-cis cis people, so if that your gender presentation doesn't match your genitals or your assignment at birth, if it does, you're called cis person. If it doesn't, genderqueer, trans, that word is really up to you. But what narrative therapy really does is it tries to break down that heterosexist and transphobic discourse around sex and gender. So what at the end of the day is that like racial and cultural and sexual identity diversity is supported by identity congruent activities and attributes. So it's not necessarily saying like if you're gay you have to do this thing, but it's saying that like if you're gay you have the option of accessing these things, and how can we find activities and places for you where you feel congruent in your identity. It's not saying you have to be a thing, you have to express your homosexuality in this way, that there are infinite ways to enact your preferred identity and finding the way that is most comfortable. So it's not about enforcing an identity that's counter to the dominant narrative either. It's simply about finding the way to enact that identity that works best for you. So it's not just like you have option A, which is dominant, and option B, which is alternative, that you have an entire beautiful spectrum of things, of identities to enact, and that there are places for you in the world to find people and relationships that encourage those identities and that allow you to express them without conflict and without feeling like, oh, well, the dominant thing doesn't work for me, so I guess I better subscribe to this other thing that doesn't really work for me either. So it just gives people space to really enact their identity in the truest, most authentic way possible. We cannot get away with talking about evidence-based practice because it's really important to discuss whether or not, or to discuss the science of it all, as I call it. So not surprisingly, narrative therapy really its focus has not been on scientist practitioners. The people who are narrative therapists are in the room with clients and less focused on research. However, but the research that has been done, and there is quite a bit, the focus really has been on qualitative research rather than quantitative research, though in recent years there's been a ton of research being done in Australia and New Zealand and demonstrates a like 74% reliable improvement of symptoms. There's also a lot of work being done in psychiatry and neurobiology, particularly by Dr. Dan Siegel, who are focusing on trauma narratives and the impact of trauma identity narratives. So the way trauma impacts your ability and your worldview. So the way trauma impacts your ability to discuss your worldview, to discuss your personal narrative, to enact your identity, and then the way also trauma changes people's ability to speak about their trauma and to create a narrative around their trauma. And the focus of that neurobiological work has really been in bottom up processing rather than top down. So instead of starting with the sort of end result and sort of trying to backtrack through it, we talk about affect, we talk about emotion, we talk about how it's impacting us and work our way bigger. So we're thinking about bottom up processing rather than top down. And it's really about the recategorization of problems from a sort of like diagnostic, medicalized to individual identity formation.
Open dialogue is another type of social constructionist approach. Its main developer and co-founder is seen here. I looked for a pronunciation of his name and really struggled. So Jaku Sukul is my best attempt. He developed this method when he was working with patients who had severe mental health problems at a psychiatric mental hospital. And he particularly found this strategy useful when he was working with these populations and they were in crisis. So this method kind of started to be explored around 1988 and has been in development ever since. It's important to remember that this method did not come out of a research setting and then be applied to clinical practice. But what happened is that he was working with these difficult populations and wanted to try new clinical approaches in order to better serve them. And this has led to the approach. So it is in fluctuation, and there is a lot of trial and error that happened at the beginning. But what originally happened was that the crisis team that normally would be centered out of the psychiatric center actually started going to the client's home and meeting with them and their family in that setting. Once they were in that setting, there was an intense involvement between all three players, the team, the individual, and the family, to create a highly individualized care plan. Now, this is extremely different from what had been happening. What had been happening before is that the professionals would be based out of those psychiatric centers, and they would be creating a care plan and presenting it to the client in isolation. So without that input by the family and the individual themselves. The care plan, once completed, would then be given to the family and the individual to sort of work with. Opposed to this new method where everyone is contributing equally, and there's no right answer, there's no wrong answer, and there's no one person who's right or who's wrong, but everyone's acting as a team, and everyone has equal input into what that care plan is going to look like. He remarked that the real transition seemed to be in the professionals. So the real there was a bit of a struggle at the beginning, but the real transition had been the professionals' outlook to include their clients and to make that more of an equal playing field. And he remarked that some of the outcomes they were seeing from this tweaking of the way they were working with these patients was that 85% of first-time psychotic patients were actually returning to work. Now, this was with medication and this was with a care plan, but they definitely found that there was a much better quality of life and that ability, like we said, to return to work and that working environment. 7 main principles of open dialogue as it was being used in Lapland, which is where this gentleman is from, is actually pulled from another video, and it is referenced here and at the end. I do highly recommend it, actually. It is completely subtexted because it is in one of the Nordic languages. However, if you don't mind reading for an hour on a YouTube screen, it is very informative. So just to go over these quickly, because I think they do sort of summarize the approach very well. The main principle is that you're offering someone immediate help. There is no sending them away, come back 2 weeks from now we'll do a formal assessment, etc., etc. There's really listening and helping immediately as much as possible. And there really is that social network perspective. So this isn't about a professional giving someone a care plan that they then have to use. It is about using all of the supports that person has available, both in their life currently and ones in the community, and really meshing them together in a way that makes sense for the client. It needs to be flexible and mobile. So the big takeaway from the way they were implementing this at the beginning and still are is that they're going into these people's homes, they're meeting them where they're comfortable, they're not coming to the psychiatric hospital. And there's a responsibility on the clinician's part and on the client's part as well in regards to working as a team. There's psychological continuity because you are employing a team approach. Everyone's on the same page from the very beginning, and the social worker that meets with you at the start is a social that works with you through the care plan in the same way that your psychiatric professional works with you the whole time. And those people have a relationship that's enduring. So you may not see your psychiatrist every week, but you may see the social worker. And those two people have a working relationship as well from the very start. There is a tolerance of that insecurity. The fact that it's not about a professional giving a plan that is a surefire way to work, but that we are all trying to formulate something that is going to work for the client, and that there's a little bit of insecurity that comes with that process and a bit of trial and error. And finally, dialogism, big component, and we'll talk about that in a second. It's all about having those open communication channels. So here are the 5 channels of information. And like I briefly outlined previously, this individual and open dialogue in general is interested in how we communicate not just with our words, but with the entirety of the conversation. So as you can see here, it's not just about how people discuss with one another, the words I say to you, and it's not just about how people respond. So it's not about how I respond to what you've said to me, but it's also about those things like our facial expressions. Do I grimace? Do I look pleased? And not just the face, but also the entire body. So how do I respond with my body movements? Am I looking closed off? Are my legs and arms crossed? All of those elements go into the conversation. The 5th one is what's particularly interesting in open dialogue and what's being researched most by this individual from what I understand is about how our bodily systems respond both to a conversation but also to our experience of psychological illness in this particular case. So how does our automatic nervous system respond? Our skin, does it react? Do we have a change of heart rate? Does our breathing change? And all of that, he thinks, should be coming into play when we engage in not just open dialogue, but any sort of therapy. It's important that we value all of these elements because the fact that we place so much emphasis on the verbalization within our methodologies may actually be at a detriment to some, and especially those that are most ill, experiencing psychiatric illness. There are emotions, and when we're experiencing those, and when somebody maybe is unable to verbalize their emotions, but the fact that they're just experiencing them should be accepted as part of the process. He cautions that we don't always need to know why they feel that way. It's not imperative that we get these people to, like many of the other methodologies we've discussed have noted, to get to the bottom of things. Their emotions need to be valued in and of themselves. And the real nugget that we should take away from open dialogue and this gentleman's approach is that he doesn't understand our need to separate the physiological from the biological, or our psychological responses from the biologic. They are all one and the same, and they should all be taken equally. So as we approach an open dialogue approach, you want to get everyone involved. Everyone as their comments are weighted the same, and every aspect of the experience of the illness or the mental health presenting problem is considered valuable and should be used as part of treatment. Just before we finish on our presentation, we'd like to present our concept map. You may recognize this image from our last presentation on client-centered therapy. And we wanted to use it again because social constructionist, of course, relies on the fact that we can only construct understanding together. So in the middle, we do have understanding, which we think is the main crux of social constructionist approach. And we have those holding hands on the outside, forming a circle to symbolize the way we construct understanding. And there you'll find all the philosophical assumptions from Harleen Anderson's video. Local discourse, dominant discourse, and power are at the corners, encompassing the whole narrative, as these influence both therapist and the client. And you can see the different therapies, techniques, and understandings on the outside circle that inform how we interact with one another. Thank you very much, and we hope you enjoy this week.